Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Saad from our University Hospital. So, welcome to PSA online lecture series on the cardiothoracic anesthesia. On the behalf of PSA Karachi, it's my pleasure to welcome you all to the PSA online lecture series on the cardiothoracic anesthesia. This academic initiative consists of 12 structured online lectures, which basically focuses on the evidence-based practices and the recent guidelines and updates in anesthesia, intensive care, and pain management. So basically, today is the 11th lecture of this series, and the topic for today's presentation is anesthetic consideration for patients with pericardial disease. So it's an honor to me to welcome our esteemed speaker, Dr. Professor Brigadier Safdar Ali Khan. He's working as a consultant in cardiac and general anesthetist at National Hospital and Medical Center, Lahore. He is also our regional faculty in American Heart Association. So we are grateful to him for joining us today and sharing his expertise. So before starting the presentation, there are some general instructions for the participants. Please keep your microphones be muted and switch off your videos during the lecture. If you have any question, you can post it in the chat box, either during the lecture or at the end. And after the completion, please fill out the feedback form in order to require the e-certificate. So over to you, sir.
Thank you very much, Saad. Assalamu alaikum and a very good morning. Very good evening to everyone who is listening or watching this lecture. Right? And I'm very thankful for giving me this opportunity to talk on a very important subject which we as anesthesiologists come across during our clinical practice. So today we are going to discuss in next 30 to 40 minutes the anesthetic consideration for patients with pericardial diseases. As an anesthesiologist, there are many patients which present to us for diagnostic procedures or therapeutic intervention. Not only they are having the pericardial disease, but at the same time they have got some comorbid disease as well. So it is a challenging task to administer them safe anesthesia. And for administering safe anesthesia, you require a thorough understanding of the pathophysiology of the disease. And to manage these patients, a multidisciplinary approach for optimal perioperative care is required, involving the cardiologist, the cardiac surgeon, the intensive care specialist, and obviously the anesthesiologist. So the learning objective of this talk today is that by the end of this presentation, the participants should be able to understand the common pericardial diseases and the condition, and what are their hemodynamic effects, and what to do when performing the pre-operative assessment, and also to identify the anesthetic goals and management strategies, and at the same time to recognize the peri-operative complication and their management. So I'll briefly touch upon everything. So first of all, let's discuss the functional anatomy of the pericardium. Pericardium is a dual enveloped sac surrounding the heart and the great vessels, and it is 1 to 2 millimeter thick. It comprises of two layers. One is parietal pericardium and another one is the visceral pericardium. Parietal pericardium is a thick fibrous outer layer which comprises primarily of collagen and elastin. It is attached to the adventitia of the great vessels, diaphragm, sternum, and the vertebral bodies. Whereas the visceral pericardium rests on the surface of the heart and it is tightly adherent to the surface of the heart, and it is composed of single layer of mesothelial cells and which is adherent to the pericardium. The visceral pericardium is responsible for the production of pericardial fluid, which is an ultrafiltrate of plasma, and this fluid provides lubrication to decrease friction between the pericardial layers. The pericardial space normally contains about 10 to 50 ml of this fluid, which is produced by the mesothelial cells of the visceral pericardium and is drained by the lymphatic system. There are two distinct sinuses are formed at point where the pericardium appears to fold onto itself. One is an oblique sinus, which is formed posteriorly between the left atrium and the pulmonary vein, and as a common location for the blood to collect after cardiac surgery. Another one is the transverse sinus, which forms posteriorly behind the left atrium, and it is situated behind the aorta and the pulmonary artery. And both of these sinuses can be easily visualized through the echocardiography. So what is the function of this pericardium? It aids in reducing friction between the heart and the surrounding structures. It also limits acute dilatation of the cardiac chambers. It provides a barrier to infection. It also optimizes the coupling of left and right ventricular filling and function. It limits excessive motion of the heart within the chest cavity, and it also has a metabolic function. It secretes prostaglandin, which affects the coronary artery tone, and it also secretes a thrombolytic substance which prohibit or inhibit the clotting inside the pericardial cavity. Pericardial inflammation or manipulation may produce severe pain because it is highly innervated, and vaguely mediated reflexes can also be seen in the form of bradycardia and hypotension. So when we classify pericardial disease, we can simply classify them as congenital and acquired conditions or diseases. The congenital one comprises partial left or right or complete absence of the pericardium. If it is completely absent, the patient does not have any symptom. The patient are usually asymptomatic. Whereas the acquired one consists of acute pericarditis, chronic pericarditis, and two conditions which we are going to discuss today, which are very important to any clinician, especially the anesthesiologist and the cardiac surgeon or any intensivist, are pericardial tamponade and constrictive pericarditis. The etiology of acquired pericardial disease includes infectious and non-infectious conditions. It could be due to viral, bacterial, tuberculous, fungal or parasitic infection, or it may be idiopathic, or maybe due to trauma, or may occur during the course of uremia in renal failure. It may be due to some neoplastic condition, may be due to autoimmune, and one condition which is called Dressler syndrome, also an acquired condition, and it's also non-infectious. So discuss acute pericarditis first. It is a self-limiting benign disease or the first presentation of an underlying infectious or the neoplastic disease. It is very important to postpone elective surgery for diagnosis and specific treatment to be initiated. Whereas the chronic pericarditis may present as the progression of acute pericarditis to chronic, to recurrent, or to relapsing pericarditis. Perioperative management will depend on the hemodynamic influence of the condition. Symptomatic treatment of pericarditis attacks are very important before initiating any other therapy, and these symptomatic treatment include pericardiectomy, which is only necessary in patients when frequent and severe symptoms occur. Moderate to large effusion should be drained before any elective surgery to optimize the clinical condition of the patient. From now onward, I'll talk about pericardial tamponade and constrictive pericarditis, which are of utmost importance to any clinician while managing a patient who is having pericarditis. When we talk about pericardial tamponade, first revisit the previous slides as well. The visceral pericardium is responsible for the production of pericardial fluid, which is an ultrafiltrate of plasma, and this fluid provides lubrication to decrease friction between the pericardial layers. And the pericardial space normally contains about 10 to 50 ml of fluid, which is drained by the lymphatic system. And the majority of the pericardial effusions are not hemodynamically significant and do not progress to tamponade. But when the tamponade occurs, when It is only when the extrinsic pericardial compression of the heart leads to diminished venous filling, leading to reduced cardiac output. And this will be explained more in pathophysiology. Tamponade may also be caused by the accumulation of clot or air in the pericardial space. Uh, Clot can, uh, I mean, they can exist in the pericardial space. They can form due to any metabolic abnormality, but air is usually iatrogenically introduced into the pericardial sac. Acute life-threatening tamponade most frequently results from bleeding into the pericardial space after cardiac surgery, which is a very common phenomenon, and it is maybe due to other invasive cardiac procedure like angiography or angioplasty, or due to ablation of the aberrant of the or the abnormal foci which are generating dysrhythmia in the heart. It can follow after a blunt chest trauma, or it may be due to the rupture of ascending aortic aneurysm or aortic dissection into the pericardial cavity. The primary symptom of pericardic tamponade include dyspnea, orthopnea, diaphoresis, and chest pain, which can be differentiated from the other causes of these symptoms. Dyspnea is often the first and the most sensitive symptom, and symptoms usually rapid in onset, but depend upon the rate at which the pericardial fluid accumulates inside the pericardial cavity. A pericardial fluid, which is in quantity about 50 to 100 ml, and it rapidly accumulates within the closed pericardial space, is sufficient to increase the intrapericardial pressure, and it also interferes with the cardiac filling, which is evident clinically as hypotension and low cardiac output syndrome. Chronic increase in the pericardial fluid will produce tamponade only if a large amount of fluid is present inside the pericardial cavity, that is sometimes maybe more than 1 liter. The primary abnormality in cardiac tamponade is impaired diastolic filling of the heart, which is caused by the elevated intrapericardial pressure that leads to compression of the atria and ventricle. The right heart is most vulnerable to the compression due to its thinner wall and lower chamber pressure as compared to the left heart. Diastolic filling pressure, left atrial pressure, pulmonary capillary wedge pressure, left and right ventricular and diastolic pressures may become elevated in this condition. Acute tamponade is often described by Beck's triad, in which you can find muffled heart sounds, jugular venous distension, and hypotension. Other common findings include tachypnea and tachycardia as well, when we are doing the diagnostic evaluation and assessment of the patient who is suffering from pericardial disease. Pulses, paradoxes may be present, but it is not only confined to the pericarditis or the cardiac tamponade. It can be found in many other conditions as well. Chest X-ray may show enlarged globular and bottle-shaped cardiac cells, and the lung fields are typically clear. Pericardial fat lines in lateral films are uncommon but highly specific findings of the pericardial tamponade. When we look at the ECG of a patient who is suffering from pericardial tamponade, the ECG may demonstrate sinus tachycardia. It may exhibit as a low voltage QRX complex, non-specific ST, T-wave abnormality, and electrical alternance. Electrical alternance is due to the swinging of the heart within the fluid of the pericardial sac, leading to beat-to-beat changes in the electrical axis. Echocardiography is the diagnostic modality of choice in evaluating cardiac tamponade. And this cardiac tamponade, it can be easily diagnosed by echocardiography. It is the most sensitive tool for making diagnosis of a pericardial effusion. Initial evaluation should focus on the presence, size, and the extent of pericardial effusion. The effusion should be measured to estimate its severity, and it can be done afterward after relieving the pericardial temperament as well. So the treatment which can be employed is the pericardiocentesis, and it can be performed with or without imaging guidance. Without imaging guidance, there is a significantly higher risk of complications such as cardiac perforation, puncture of the coronary or internal mammary arteries, and pneumothorax. But with the help of echocardiography and with the help of fluoroscopy, it can be performed with precision and with more safety. A catheter is frequently left in the pericardial space to allow for continuous drainage once we place the catheter in a proper position. The ultimate treatment is the surgical drainage if it is not being relieved by the pericardiocentesis. An indication for surgical drainage include unsuccessful pericardiocentesis, localized or loculated effusions, when we have to remove a clot from the pericardial space, and ongoing intrapericardial bleeding. The surgical approach is primarily via sub-xiphoid pericardial window or a small anterior thoracotomy as we do in the cardiac surgery. The goals of the perioperative care are very clear. Pre-medication with the anxiolytic or opioid should be avoided as far as possible, and to facilitate ventricular filling, preload should be optimized with intravenous fluid prior to induction. An invasive blood pressure monitoring is strongly considered by putting an arterial line. There should be an adequate intravenous access, because if large amount of fluid are to be transfused, then we should have an adequate and a large bore intravenous cannula. Central venous access may be beneficial both for the fluid resuscitation and for the central venous pressure estimation and monitoring. And before proceeding with induction of the patient should be fully wrapped and draped. Surgical team be immediately available to make incision in the event of hemodynamically instability or collapse during the induction. The perioperative anesthetic plan should have the following hemodynamic goals. Reduction in heart rate, that the bradycardia should be avoided as far as possible. Contractility of the heart should be optimized to preserve cardiac output, as these patients have both a fixed and reduced stroke volume. Adequate preload is essential to promote right ventricular filling by infusing fluid or blood. Decreases in the systemic vascular resistance are particularly detrimental, as this will reduce right ventricular filling and systemic perfusion pressure. Positive pressure ventilation can cause a dramatic decline in preload and cardiac output. Patients with tamponade be allowed to breathe spontaneously as far as possible until the pericardial sac is opened and drained. If spontaneous ventilation is not possible in any case, then ventilation with high respiratory rate and low tidal volume should be considered to minimize elevation in the mean airway pressure and to avoid the complications which are being caused by the mechanical ventilation. For induction, etomidate appears to be a reasonable induction agent. Benzodiazepines are also a reasonable choice, but ketamine, which appears to be a drug which stimulates sympathetic system and provide relatively stable hemodynamic conditions, may be used, or sometimes if it is used in large doses, then the sympathetic stimulation role of this ketamine can be unmasked, and it can cause harm rather than providing any benefit. Opioid should be given with caution, because vaguely mediated bradycardia can significantly diminish cardiac output. Inotropes and vasoconstrictors are often needed to maintain cardiac output and peripheral vascular resistance. Now, we'll talk about constrictive pericarditis. Let's talk about the types and etiology of constrictive pericarditis. Constrictive pericarditis is a diagnosis that encompasses a wide spectrum of diseases. It can be effusive constrictive pericarditis, or it may appear as a localized constrictive pericarditis involving only the parts of pericardium with variable hemodynamic sequelae. It can be occult pericarditis, in which a rapid infusion of intravenous fluids can provoke the signs and symptoms of disease. And the most common causes of constrictive pericarditis are idiopathic, viral, post-cardiac surgery, after mediastinal radiation, and in developing countries, the most common cause is tuberculosis. When we talk about the symptomatology, the most common presentation of this chronic and progressive chronic disease is the chronic and progressive fatigue, orthopnea, dyspnea on exertion, peripheral edema, and abdominal distension. We have to make a differential diagnosis of this constrictive pericarditis from other entities such as hepatic failure, right ventricular failure, tricuspid valve disease, and restrictive cardiomyopathy, because they can present in the same manner as constrictive pericarditis. As the pathophysiology of this underlying condition is markedly different, the medical and the surgical management varies considerably as well while treating the other condition which appears to be in differential diagnosis. We have to understand the pathophysiology of constrictive pericarditis. There is an impaired diastolic filling. In the non-compliant pericarditis, the pericardium limits the filling of all cardiac chambers, so resulting in a state of low cardiac output. In this condition, the atrial systole does little to augment left ventricular filling, and cardiac output is maintained only by compensatory increase in the heart rate. Dissociation of intrathoracic pressure is an important consideration. The rigid pericardium isolates the cardiac chamber from the negative pressure generated during the inspiration. Ventricular interdependence is exaggerated in constrictive pericarditis. So, when there is increased filling of or increased pressure in the right ventricle, it moves the interventricular septum toward the left side, and when it moves the interventricular septum to the left side, the left ventricular filling is compromised and cardiac output is also compromised. And one of the most important consequences of the pericardial constriction is a significant respiratory variation in left and right ventricular filling patterns. When we perform the clinical evaluation in cases of constrictive pericarditis, the diagnosis is difficult to make on history and physical examination alone, but must be considered in patients presenting with the signs and symptoms of venous congestion. On examination, the jugular venous distension with Cosmo sign, that is an increase in the jugular venous distension on inspiration, and Frederick sign, a rapid decrease in the jugular venous distension during early diastole, may be present. Pulsus paradoxus is variably present, and on cardiac auscultation there is a pericardial knock which is audible, and it is a sound which appears during the diastole and before the first heart sound. When we do laboratory assessment or investigation, it can reveal organ dysfunction secondary to the disease process, that it may cause kidney injury or due to low cardiac output or elevated liver enzyme due to liver congestion. Natriuretic peptide levels are usually normal or only slightly elevated, and this is attributed to the rigid pericardium limiting the amount of potential chamber dilatation. When we see the ECG findings are non-specific and may include sinus tachycardia, atrial fibrillation, conduction delays, P mitral, and ST segment and T wave changes. While calcification of the pericardium is not universal, its presence on the lateral chest X-ray may suggest constructive pericarditis. A thickened pericardium more than 2 mm may be appreciated on CT scan or MRI and other imaging techniques and demonstrate the pericardium being adherent to the myocardium. It can also be diagnosed on fluoroscopy. It may be helpful in the diagnosis of effusive constrictive pericarditis, with some suggesting its routine use during the drainage of pericardial effusion. If it is done, it is very safe. When we do the echocardiography, it is essential for the diagnosis of constrictive pericarditis, and more advanced techniques have become useful in its differentiation from the other disease processes. While talking about the treatment, the definitive treatment of cardiac tamponade is emergent drainage through either pericardiocentesis or surgical decompression. Pericardiocentesis may be performed with or without imaging guidance. Imaging is often preferred to assist in safely guiding the needle tip through the pericardium to the most optimal location for drainage, and indications for surgical drainage include unsuccessful pericardiocentesis, localized or loculated effusions, removal of clot, or ongoing intrapericardial bleeding. When we decide to operate upon a patient who is suffering from constrictive pericarditis to relieve the obstruction and the tightness and the symptoms of the patient, we should have these goals of perioperative management in our sight. Pre-medication with benzodiazepine or opioid must be titrated judiciously and according to the patient's preoperative hemodynamic status. One of the most important things in constrictive pericarditis is to maintain the hemodynamic status of the patient. The sympathetic nervous system plays an important role in maintaining cardiac output, and any inhibition may lead to the clinical and hemodynamic deterioration, and this usually occurs with the use of anesthetic drugs or when all the system or all the reflexes which are maintaining the cardiac output in an awake patient are being abolished. The perioperative anesthetic plan should have the following hemodynamic goals. Reduction in the heart rate should be avoided and contractility optimized to preserve cardiac output, as these patients have both a fixed and reduced stroke volume. Adequate preload is essential to promote right ventricular filling, and a decrease in systemic vascular resistance is particularly detrimental, as this will reduce right ventricular filling and systemic perfusion pressure, causing compromised function of different vital organs. Positive pressure ventilation can cause dramatic decline in preload and cardiac output. It is therefore suggested that these patients with tamponade and constrictive pericarditis to be allowed to breathe spontaneously until the pericardial sac is opened and drained. If the spontaneous ventilation is not possible, ventilation with high respiratory rate and low tidal volume should be considered to minimize elevation in mean airway pressure. Patients with constrictive pericarditis are often requires invasive monitoring. An arterial line is beneficial, and as it will record beat-to-beat pressure and helps in maintaining the hemodynamic stability, which is the prime requirement in these patients. Adequate intravenous access through a large bore intravenous line is essential. Central venous access, which allows rapid infusion of the intravenous fluid or blood product and vasoactive drugs, as well as the monitoring of the central venous pressure, is always recommended when we are operating upon a case of constrictive pericarditis. Perioperative cardiac output monitoring via pulmonary artery catheter or pulmonary Swan-Ganz catheter may be beneficial, but it requires a lot of expertise and special equipment. Intraoperative transesophageal echocardiography provides useful information for both the surgeon and the anesthesiologist, in particular with regard to the ventricular filling and function. And intraoperative transesophageal echocardiography is the modality of investigation and modality of treatment and management in current day practice, and supposed to be and all the cardiac anesthesiologists are supposed to know this technique. It is really very beneficial in treating patients with hemodynamic instability. Pericardiectomy requires general anesthesia, and care must be taken to avoid hemodynamic deterioration during induction and the maintenance of anesthesia while treating a patient of constrictive pericarditis. Preload must be maintained and often augmented to ensure cardiac filling and reduction in either preload or afterload that are usually poorly tolerated. An elevated heart rate plays an important role in the maintenance of cardiac output and bradycardia, and can be, if they occur, they can be particularly very detrimental. While the atrial kick does little to enhance ventricular filling in patients with constrictive pericarditis, extreme tachycardia such as atrial fibrillation with a rapid ventricular rate may be poorly tolerated and should be avoided as far as possible. Contractility should be maintained, as significant myocardial depression will adversely impact cardiac output and systemic flow, and this contractility can be maintained with the help of inotropic and pressor drugs. Based on these hemodynamic goals, induction and maintenance of anesthesia involves similar consideration as previously described for the patient presenting with the tamponade. Vasoactive medications must be readily available to offset any perturbation caused by the anesthetic agent or surgical manipulation, most notably decreased preload, afterload, contractility, and heart rate. Surgical blood loss and coagulopathy may be significant, and they require aggressive resuscitation and correction of underlying coagulopathy. To conclude my discussion or a talk, I must say that the pericardial disease can be challenging for the attending anesthesiologist. Therefore, an in-depth understanding of the pathophysiology of each disease state is necessary to provide optimal care. Careful preoperative evaluation of the clinical history, examination, and diagnostic investigation will allow adequate evaluation of the risk and alert the anesthesiologist to the necessary steps to be taken to manage these patients in the safest way possible. And I thank you all for a very patient listening. Now, any comment or question are most welcome.
Thank you so much, sir, for the wonderful talk. You've covered all the topics related to the physiology, like pericardium, which is required for the safe anesthetic management to preserve preload, maintain cardiac output, and to tailor the anesthesia according to the underlying pathology. Thank you so much, sir. So, any questions or any comments, you can share it on the chat box. Sir, there is one question. How much PEEP is acceptable in patients with tamponade?
Okay. There's a relative figure, You cannot say that PEEP of 5 or PEEP of 6 or 7 is essential in these patients, you have to adjust PEEP or titrate PEEP according to the requirement of the patient and according to the hemodynamic status of the patient. Maybe in some cases, as we usually operate the constrictive pericarditis cases, I do not apply PEEP in first place, and I only apply PEEP when the chest is open through the thoracotomy, right? So when the chest is not open, you can apply PEEP in a titrated fashion, whatever PEEP is tolerated by the patient, and it's not compromising the hemodynamic status.
Thank you, sir. Hope Dr. Safdar cleared the answer. Dr. Amber, any other questions? So, all the participants, you are requested to please the evaluation form. We will share it in the chat box very soon. So, any other questions or any comments?
Thank you, sir. It's clear now.
Sir, no more comments and no questions. I think it's clear from every aspect. Or you can ask any questions.
There's nothing left in the box for the question. I've already explained whatever I could, but this is just food for thought. You can consult books on this, and you can formulate your own technique while anesthetizing these patients. First of all, I will strongly recommend to make a checklist whenever you are anesthetizing a patient with constrictive pericarditis. How you have to proceed, how many manpower do you require for this? A consultant anesthesiologist, an assistant, a technician, or a technologist, and then what drugs do you require? So you have to have a complete checklist. How many intravenous access do you require? Do you require an arterial line, or do you require a central venous line placement? And what other drugs like the inotrope or the vasopressors or other drugs are required in this? And do you require a transesophageal echocardiography? So because these patients are really very sick patients and they do not come in our clinical practice very often. We rarely experience anesthetizing patients with the constrictive pericarditis and with the cardiac tamponade. So we should make a checklist for those patients or those conditions which we are rarely experience. So this is one of the suggestions, and which is the practice which I usually do. So I thank everyone for patient listening, and thank you very much, Saad, and thank you very much, PSA, for giving me a chance to speak on this very important topic.
Thank you so much, sir, for an excellent talk. Thank you so much. I would like to thank to all the participants as well for joining us online. We're looking forward for your active participation in future as well. So we will share the link in the chat box soon. I would like to request the admin to please share the link so that the participant can evaluate and fill out the feedback form. Thank you so much, sir.
My pleasure. My pleasure. Allah Hafiz. Assalamu alaikum.
Thank you.